Okay. Hello, everyone. Good morning, good afternoon, and good evening, depending on wherever you are. Welcome to our special COVID-19 session number 22. This is a series that we have dedicated to diagnostics in the COVID-19 pandemic. And as usual, these sessions will be 1 hour long. We shall start with a presentation and then we go into a question and answer. My name is Anafi Mataka, and as usual, I'm always glad to be your host. Today, we are going to be discussing a very important topic, which is on specimen collection using nasopharyngeal swabs. As you all know, nasopharyngeal specimens are the WHO recommended specimen of choice for detection of SARS-CoV-2. However, we realize that we have always had challenges in many places, particularly with shortages. Not only shortages, but not only shortages of the swabs themselves, but also PPE for health workers, which also may act as a barrier for collection of these specimens. So today we have Karen Hashman and team from the Bill and Melinda Gates Foundation, who we have been working hard around innovations that could actually surmount the barriers that we have had with specimen collection. So Karen is currently a senior program officer in the Innovative Technology Solution Program within the Global Health Division at the Bill and Melinda Gates Foundation. She normally divides her time between leading the development of efforts in TB diagnostics, as well as evaluating novel technologies for global health. Prior to coming to the Bill and Melinda Gates Foundation, she has held positions in many organizations. For example, she has been the former VP of New Technology Assessment and the founder and director of PharmaDX program at Arup Laboratories, which is a large national reference laboratory in the US. She has also held positions such as Vice President of Proteomic Research at the Media Genetics. She has also been a Director of Cancer Systems Biology at Huntsman Cancer Institute, as well as being an adjunct professor of pathology at the University of Utah, and being also a Vice President and Director of the PharmaDX program at Arup. So as I hand over to Karen, I would like to remind you to put your questions and comments into the chat box, and we shall respond to these after the session. Kind reminder to all of you that we have simultaneous language interpretation, English to French. So please feel free to choose the language of your choice. Ladies and gentlemen, let me hand over to Karen to take us through the presentation.
Thank you very much. It's really my pleasure to speak to you all today and tell you about the work that we've been doing together with our colleagues and partners over these past several months since the COVID-19 outbreak and now pandemic. It's especially an honor for me to present to you all, as Anafi mentioned, that I came from a central national reference laboratory before coming to the foundation. And I worked very closely with career professional laboratorians like you all, and have a special fondness for people in the laboratory industry. So it's my pleasure to present to you today and hopefully give you some ideas about the work that we've been doing, and also a move forward in a transition from nasal pharyngeal swabs as the specimen of choice to a lower nares or nasal swab specimen that is it gives very good performance, high quality, and also some added features regarding specimen stability that would be useful for transport in the absence of cold chain. Back in early March, even in the United States, it was clear that nasal pharyngeal swabs were one of the many components that were in short supply and were critically limiting for testing for SARS-CoV-2. And together with two different partners in the laboratory industry, the Everett Clinic, which is part of the United Health Group clinics in the northern part of the Seattle area of Washington, which was the site of the first outbreak of SARS-CoV-2 in the United States, together with Stanford Medical School, we undertook to evaluate the performance of a lower nares or nasal swab as compared to the traditional swabs that have been used for upper respiratory specimen collection, the nasopharyngeal swab and the oropharyngeal swab. These data that I'm showing you here have been published in the New England Journal and in JAMA Online as letters, and I'm going to give you a little bit more detail around the data that wasn't included in those publications, but you can certainly read about this yourself. In the first study on the left, the Everett Clinic set out to collect specimens from patients that were presenting with upper respiratory symptoms in the northern Seattle area during the first part of the outbreak. And they collected nasopharyngeal swabs by a healthcare worker for all patients seeking care, and this was used for diagnosis. At the same time, a number of alternative swab collection sites were performed, including a self-collected nasal swab in both sides of the lower nares. These data shown here are the comparison of the patients that had both nasopharyngeal swabs as well as nasal swabs collected. And you can see by eye that there was very good agreement between the positive specimens as well as the negative specimens. And also you can probably appreciate that the percentage positivity was very high in this population during that time of about 10%. And this was consistent with reporting in the region. There was 94% positive percent agreement amongst the positives that were determined by nasopharyngeal collection as compared to the lower nares collection using a foam swab, and very good concordance as well between the negative specimens. You can see that there were a small number of discordant specimens, but these fell on both sides, where in some cases the nasopharyngeal gave a positive result and other cases the nasal gave a positive result. But overall, there was very good percent agreement. If you look at the quantitative amounts of virus that were detected by the two methods, and this was using the Roche Cobas method as tested in Quest Diagnostics laboratories in the US, you can see that for both of the target genes, the ORF1 and the E gene, there was very good agreement between the cycle thresholds using the two different methods, the nasal or the nasopharyngeal swab. So not only were the clinical results concordant, but there was very good agreement amongst the analytical results as well with regard to the viral load as assessed by the cycle thresholds. At the same time, a study was being conducted at the Stanford Medical School where patients that had already been tested positive for SARS-CoV-2 were invited to return to the drive-through clinic to have another collection and testing occur. In this case, an oropharyngeal swab was used as the comparator as collected by a healthcare worker. And then two sets of nasal swabs were collected. The first was collected by an individual themselves in both sides of the nose. And the second was collected by a healthcare worker, again in the lower nares. And you can see here that there was, again, very good agreement amongst the positives and the negatives. These data were shared with the US FDA in real time, actually at 10 o'clock on Sunday night for the Everett Clinic study. And the very next day, the FDA updated their guidelines to include lower nares or nasal swabs as an appropriate specimen type for collection for SARS-CoV-2 testing. In fact, the Everett Clinic and all of the United Health Group clinics went on to only use the lower nares swabs for clinical patient testing at that point. And it began really the approval of the use of the nasal swabs, which have been used around the United States in a number of public health labs as well as private labs. I did speak with Quest Diagnostics about a month ago, and it was my understanding that the vast majority of specimens that are received in their labs are now comprised of lower nares swabs, and often swabs that are made of spun polyester. And I'll tell you more about that, but I did want you to know that these lower nares swabs are now widely used in the United States. Not in every lab or every situation, but certainly in ones where it's important for an individual to collect their own specimen. I'm sure you can appreciate that this might be very important in a setting of children going back to school or individuals going back to work, where they need to have multiple different specimen collections occur so that they can be tested and deemed to be negative. The next slide illustrates some very important information about the way that the nasal swabs are collected. These instructions were developed by our grantee Odere that has a digital health solution that educates an individual on how to collect their own lower nasal swab, and also prepare the sample for shipment to the lab by a commercial courier. This could also occur by a laboratory courier or by an individual bringing their specimen to the lab. But suffice it to say that there's a process in place for a swab to be collected by an individual, placed into a tube, which is then placed into a biohazard bag, and then taken to the lab for testing. It's very important that the swab collection be done purposefully, where both sides of the nose are swabbed with the same swab device. And that in the swabbing motion, the swab is placed inside the lower part of the nose, and the entire inner surface of the nose is contacted with the swab for 5 revolutions, 4 to 5 revolutions on each side, to get a good comprehensive collection of material from the inside of the nose. At the beginning of the outbreak, not only were the flocked nylon nasopharyngeal swabs in short supply, but the foam nasal swabs that were used in those original studies also came under supply constraints, most notably because the US government actually bought up all of the foam swabs, and so there were no more left for patient testing in the United States. And so we set out with our partners to rapidly understand whether an alternative nasal lower nares swab could be used in the place of the foam swabs that were the subject of those first studies at the Everett Clinic and at Stanford. A series of comparisons were performed of the foam swabs and the spun polyester swabs, and largely these were shown to be equivalent. One interesting point is that actually the polyester swabs work better in an alternative transport media, either in saline or in dry format. And I'm happy to share those data with you in the subsequent slides. One thing that's important, though, about the polyester swabs is that these can be manufactured at a much higher scale and a higher capacity than foam swabs. And COPAN themselves were urging us to evaluate the polyester swabs in the very early weeks of the outbreak because they knew that these could be manufactured at much higher scale than flock nylon. Indeed, the foundation is engaged with a US-based company called US Cotton that makes swabs that look very much like the ones shown here on the right. These are similar to ones that are manufactured also by COPAN and other manufacturers and are very inexpensive to make. We're in the process of working with US Cotton and a company called SteriPack that will individually package and sterilize these swabs at a much reduced price as compared to the Puritan or the COPAN swabs. And we're also in the process of negotiating preferred pricing for low and middle income countries that would be much less expensive to perform and would make it so that these swabs actually could be pre-positioned in laboratories, in sites of places of work, or in schools, or in the home, so that at the sign of infection, a person could collect their own specimen with the swab that they already had in their home. We're gearing up now with US Cotton and SteriPack to manufacture 1 billion swabs or more per year. And these could be sent to multiple locations in the world. SteriPack also has multiple sites has a site in Asia and 2 in Europe, making it much easier to ship to Africa. We've been working closely with some of our grantees on the continent who have been conducting early evaluations of these spun polyester swabs, including our colleagues Wendy Stevens and Leslie Scott at WITS, and they've demonstrated very good performance of the US Cotton SteriPack spun polyester swab. And I'll let them share the data with you at another time, but suffice it to say that these are performing very well and are currently in clinical use in the United States in a number of locations. The next question that we sought to address with our grantees was whether viral transport media was important for the collection of the nasal swab, as this was again the historical transport media that was used for collection. At the time, a number of different laboratories in the US were evaluating alternative transport media, and we decided to evaluate whether sterile saline would be equivalent or have better performance than VTM using the nasal swab. And in fact, both foam and polyester swabs that are collected from the lower nares demonstrate excellent performance when using a nasal or when using saline as the transport media. And in fact, the performance was better than using VTM. We've certainly heard from other laboratories that VTM can actually be inhibitory to some PCR and molecular methods. And so it was very nice to learn that saline was an appropriate alternative. One of the questions that arose in speaking with clinicians is whether it would be possible to collect a lower nares specimen and then send that specimen to the lab in a dry tube, in a tube containing no transport media at all. The thinking was that those swabs might be more stable and would be less subject to contamination of people handling those swabs, and would allow for the laboratory or the operator to elute the swab material, the specimen, into a buffer of choice and in a volume that is convenient and would preserve the sensitivity of the specimen. I know you can appreciate that many times the amount of transport media that's already in the tubes approaches 3 mils, and that would result in a very dilute specimen. By using a dry tube, you can elute in 1 mil or less and really have a more concentrated sample to work with. And you can also use your choice of buffer for elution. The work that's been conducted by our grantee, Quantigen Biosciences, has evaluated and validated the use of 1 mil of phosphate buffered saline, or PBS, to elute the material from the swabs. These data have been shared with FDA, and like the other data that I'm going to share with you today, have all been included in a file that's available for reference. And what that means is other laboratories and IVD manufacturers may reference the data surrounding the nasal swabs, the use of a dry swab, and the stability that I'm going to share with you, in addition to elution and PBS, and not have to revalidate those particular steps. I will tell you that my colleagues at WITS, though, have been looking at the dry swab format, and they are also seeing very good stability and the ability to remove the specimen material from the polyester swab using a similar method. These are data that demonstrate the comparison between the polyester nasal swab as compared to the foam swab on the X and Y axes in 2 different transport media, in viral transport media and in saline. And I think that you can appreciate that there's very good concordance between the different methods. And if anything, there's better concordance and performance when saline is used as the transport media. So the data that I'm going to share with you continuing forward evaluate the use of no transport media at all as comparison to saline for nasal swabs. I did want to spend a minute talking about the elution protocol for using the dry swab, and it really is quite simple, although I don't believe there are many laboratory procedures that look just like this. But the method that's been developed and validated by Quantigen involves adding a ml of PBS to the empty tube that contains the dry swab, vortexing for 30 seconds with intermittent pulsing, and then letting the swab sit for 10 minutes or more prior to removing the liquid for extraction. The following elution methods have been tested and are not recommended because there's not a good quantitative removal of the material from the swab. So merely swirling the swab in a ml of PBS does not work well for molecular testing, nor does a scenario where the swab is just placed into PBS, but no vortexing or swirling occurs. I have heard that academic institutions in the United States have developed a method for orbital shaking of specimens containing that 1 ml PBS, and there is good elution using that method, but we have not evaluated that through our grantees at all. So that would be up to the laboratory to determine whether this could be used. Modifications that have been tried that do work are elution into smaller volumes of PBS, and again, concentrating the sample. And our colleagues at Quantigen Biosciences have demonstrated that elution into PCR buffer has worked very well for them when using the Thermo Fisher method. And this would allow for direct PCR without an extraction step in between. These data are being generated now, and I'd be happy to share them with you once they're collected. But suffice it to say that a simple heating step is sufficient in PCR buffer to allow for direct PCR from the swab material without extraction or purification in between. These are the data that were collected to, or the study design around the dry stability studies, where 3 study arms were evaluated. The use of foam nasal swabs that were collected into a dry tube was one comparator. A dry polyester swab was a second comparator, and the third were the polyester nasal swabs that are stored in saline as opposed to a dry tube. Specimen pools were collected from actual patient specimens that were not inactivated in any way, and these were used to dilute into a pool of negatives, including clinical matrix. The samples were then made in 2x the limit of detection, the low positives, and 10 times the limit of detection, the high positives, and multiple replicates were made in those 3 different study arms. I'm showing you here the experimental conditions where these swabs were all treated with a heat excursion of 12 hours at 40 degrees centigrade, followed by variable lengths of time at 32 degrees centigrade, followed by 2 hours at room temperature to re-equilibrate the swabs in the laboratory prior to testing. For the low positive samples for each of the time points, there were 20 replicates for each time point. And for the high positive arm, there were 10 replicates for each of the different time points following the temperature excursion. The acceptance criteria for the low positives was greater than or equal to 95% positive, and for the 10 times LOD or the high positives, there was required 100% positivity to meet the acceptance criteria for stability at those elevated temperatures and at those various times. This is a summary of the data that were collected to support the nasal swab stability. The first 3 panels are the time 0, the 24 plus 8 hours, and the 48 plus 8 hours. And suffice it to say that all of the conditions met acceptance criteria, where there were no samples that failed that did not give a positive test result, either in the very near the limit of detection or the high positives. And this really demonstrated that all three conditions, the dry foam, the dry polyester, and the dry saline samples, were stable even in the absence of cold chain and in the presence of a heat excursion. And this was really very exciting for us, that it looked like a specimen could be collected remotely at home or in the workplace or in a community setting, and then would be stable without cold pack when shipped to the lab for testing. The third panel illustrates the results of the 3-day time point, and you can see that all but one of the conditions met acceptance criteria, where up to one of the 20 replicates in the low positives was allowed to be negative in order to meet acceptance criteria, but none of the high positives could be negative in order to meet acceptance. Only in the case of the most dilute sample of the polyester swabs that were in saline did you see dropout of any of those positives. But I would note that in the high positive samples, which had a cycle threshold around, I want to say 27 or sorry, 31 to 32 or 33, these all were positive. And so you can see that all of these different conditions are stable through 2 days without any cold support. And only on the third day, in the case of the most dilute specimen, and in the case where the swab was placed in saline, do you start to see some degradation of the sample. In contrast, the dry swabs were very stable to 72 plus 8 hours. And these data were also shared with the FDA and are now made available for other labs and IVD manufacturers to reference these data, so that if they use a dry nasal swab, they don't have to conduct temperature stability studies or shipment stability studies in order to use those without cold chain. And in fact, in the United States, a number of different laboratories as well as IVD manufacturers have referenced these data and are using a self-collection method for lower nares swabs, including that on their instructions for use of their laboratory developed tests or their in vitro diagnostic tests that have received emergency use authorization at the FDA. I won't go through all the data here, but I did want to show you that with regard to the individual cycle thresholds, you can see that the cycle thresholds did not go up appreciably for any of the time points, indicating that the viral load was going down in these specimens during the time course. And only in the setting of the most dilute sample in saline did you start to see really large increases in cycle threshold, indicative of reduction of viral load. In this case, we were highlighting for you the ones that had cycle threshold changes of 3 cycles or more. And you can see that in the case of the S gene using the Thermo Fisher assay, those were no longer detectable, but only in the 2 times LOD and saline. I showed you here also in the lower right-hand corner the mean cycle thresholds for each of the 3 genes across different days from time of symptom onset for the patients that were included in another longitudinal study. And you can see that the dilutions that were used here for this study were in the range of what you would see in patients 7 to 10 days from the time of onset of symptoms. So these dilutions are used at very low viral loads, equivalent to the time when patients are becoming no longer infectious. And so the samples then are very stable, we think, through the infectious period, all the way through potentially day 10, when a person would no longer be considered infectious, and probably the virus that you're detecting are viral remnants without the ability to culture live virus. So I wanted to return to the notion of using an alternative manufacturer for the spun polyester swab. The original work that was done comparing the foam and the polyester swabs was done with a Copan spun polyester swab. And what we wanted to do is see if we could evaluate and validate the performance of the US cotton polyester swab that can be manufactured at very low cost and at very high scale, and would be available for low and middle income countries and could be distributed more broadly outside of the United States. So we became engaged with US Cotton very early on once the swab stability was established, and have been working with them as a grantee to, or working with SteriPack, which is the the company that individually packages and sterilizes those swabs, to build out their manufacturing capability so that they can expand the number of swabs that are produced, and also expand the ability of those swabs to be used for self-collection. One of the features that was included in the packaging of the swab, so the individual packaging, is the ability to add a 2D barcode, which is used by another grantee of ours to allow an individual or a healthcare institution to register a person into a healthcare system by scanning the barcode that's on the individual packaging of the swab. Not only does it allow for the person to be registered and to have their records and their results linked to their healthcare record, but also it allows for the individual or the healthcare worker to bring up a phone-based or computer-based application that illustrates those visual and textual instructions for collection of the swab for both sides of the nose and the appropriate use of collecting material from the entire inside surface of the nose. So really those instructions that I showed you on one of those early slides is what is launched by scanning that 2D barcode. As I mentioned, SteriPack and US Cotton have the potential to increase the capacity to 1 billion swabs per year, and are in the process of building an automated solution in order to achieve that goal. The foundation has been working very closely with CHI, as well as a number of IVD manufacturers and laboratories, to introduce these swabs to not only end users in the United States, but really outside of the United States in the geographies that the Gates Foundation really seeks to enable. I have distributed batches of swabs that are free of charge for evaluation to a number of sites in Africa, including our iLead grantees in Senegal, Mozambique, and in South Africa, who have begun the assessment of these swabs. These have been tested using a number of back-end molecular methods, including Cepheid and Roche and Abbott, as well as Thermo Fisher. And all the results that I've been hearing about have indicated that these swabs work very well for molecular testing. Of course, individual laboratories would need to evaluate the use of a dry swab and the method that they would use for elution of material. But a 1 mil PBS and a small time of vortexing, while not very automation friendly, is a method that is easy to use and gives very good results. As I mentioned, we've been working very closely with our grantee Odere to customize the labeling of those individual swabs and include that 2D barcode, which would link then the individual to electronic swabbing instructions and other functionality. That can be customized by individual procurers of those swabs, and I know SteriPack is very happy to work with individual countries or larger institutions that would like to procure those swabs with specialized functionality on the labeling. They're also very interested, and we're in discussions with them and CHI about preparing individual collection kits that are also include a dry tube as well as those instructions and the box and bag for shipment, or can make customized kits that are minimally include the swab and the tube. I won't go into a lot of details, but this really summarizes some of the early work that was done, again, with US Cotton and SteriPack. And the cost of these swabs, while still needs to be finally negotiated, will probably approach 20 cents or less for each swab, which compares to the Copan swabs, which are, and the Puritan swabs that cost between $1 and $2, which don't necessarily include the tube and the media. And so we think that these swabs may be a very good source of high quality, yet and high capacity swabs for use in molecular testing. I will add that recently one of our foundation partners has evaluated the use of these swabs for a direct antigen test. And in fact, they're using these swabs and have them on their label for the direct antigen testing using a small reader. The company is called Lumira, and they have a strip-based test. Not a lateral flow, but more in the way of microfluidics for direct antigen testing and a small reader. And we're in the process of working with the company to provide those instruments and test strips to the continent for evaluation in procurement. And again, these swabs have been evaluated and are included on the label for use with that direct antigen test. Ultimately, we hope that these swabs will be useful for collection of specimens for lateral flow testing, and we're in the process of working with the IVD manufacturers that make lateral flow strips to incorporate a nasal swab, self-collected, as well as the use of the polyester swab for those particular devices. So just to conclude then, the nasal swabs show equivalent performance to NP and OP swabs in a range of viral loads seen in COVID patients through at least 10 days from the start of symptoms and during the infectious period. The limited detection of the test that was being performed, the Thermo Fisher test, in the hands of our Quantigen Biosciences grantees has demonstrated that the limit of detection is around 10 copies per PCR reaction. And these swabs are very good and useful for those indications all the way through that low viral load. I didn't show you these data, but the self-collected nasal swabs demonstrate adequate and reproducible amounts of material as assessed by RNase-P in those samples. And also usability studies conducted by our grantee Odore demonstrate that a self-collection of a nasal swab can be done in a very usable manner, and that individuals can collect material that give very good RNase-P values when using those specific instructions. The spun polyester nasal swabs have similar performance to the foam nasal swabs in VTM and have better performance and greater concordance with foam and saline. We actually advocate now for use of the polyester swabs in a dry tube, as it exhibits greater stability and is also easy to use and does not have as high of risk of contamination of an individual in the lab or a courier that might be transporting that tube. The dry polyester swabs may be eluted in a millipbs with 30 seconds of vortexing. There may be other methods that would work, but probably this would require some kind of mechanical agitation. The US cotton polyester swab has demonstrated equivalent performance to the Copan polyester swab that can be procured at the higher price for the Copan and a much lower reduced price for the US cotton swab that's packaged by SteriPack. Studies have demonstrated this to be true by looking at RNase-P values in normal healthy volunteers, as well as making contrived specimens with human volunteers with normal human mucus and epithelial cells collected by human volunteers that are spiked with known positive material. So these are actual positive specimens, not viral RNA that has been that's been extracted and eluted. Stability for the dry swabs has been established at actually 72 hours plus 8 hours in the high temperature excursion. The FDA only would allow a claim of 48 plus 8 hours for the labeling in the United States. But our data did clearly show that even with a temperature excursion, that 72 hours would be acceptable in the dry swab format. However, the swabs in saline are still stable up to 48 plus 8 hours, and therefore could be used in that format as well. The samples have been demonstrated to be very stable when refrigerated. This is really a minimal time point. We know that refrigerated dry swabs are stable for a very long time, and this may be useful for, hopefully not for patient care where there are a lot of backlogs, but potentially for surveillance or other applications. I did want to end on a final note because the work that we've been doing around COVID has really prompted us to think a lot about multiple different types of respiratory illnesses that could use a self-collected specimen and potentially a nasal swab or an alternative swab such as an oral swab or a tongue scraping. As was introduced to you when I myself was introduced, I work closely with our TB team at the foundation and support them in diagnostic development. And I have several grantees that have been evaluating the use of a tongue swab as an alternative specimen collection to sputum. And in fact, my grantees are now looking at the use of the polyester swab for use in TB nucleic acid testing, and are also evaluating the stability of those swabs in dry format. The idea would be that a tongue scraping could be used for TB testing in dry format and potentially could be used also for COVID testing. I didn't mention to you this at the outset, but that original study at the Everett Clinic also had a study arm that looked at the use of a tongue scraping for COVID detection. And while the tongue swab wasn't quite as sensitive, we do believe that there are ways to collect more material with the swab, and it might be possible to have a test that would be a combined TB and SARS-CoV-2 test from a single tongue scraping. And indeed, I have different grantees that are looking at that for molecular and are also looking at whether direct antigen testing and TB nucleic acid testing could be performed for SARS-CoV-2 and TB. As I mentioned, we're also interested in whether those swabs, nasal swabs that are self-collected, could be useful for other infectious diseases such as influenza A and B. And in fact, our grantees are also looking at whether the lower nasal swab could be useful for a combined test that is multiplexed or individual PCR reactions, but would include SARS-CoV-2, influenza A, and influenza B. And I know that the FDA has been, in the United States, is very open to a multiplex test using the nasal specimen. Indeed, nasal specimens have been used for years by IVD manufacturers, including Quidel, that has a lower nasal swab that can be used for influenza. And they are also planning a test that would be combined as well. So as I mentioned, there are a number of different grantees and partners that are already evaluating this, including my colleagues at WITS, with whom I've been very closely coordinated over these past several months. And they have in real time been evaluating the use of nasal swabs and then the spun polyester as well as the dry format, and are evaluating those on multiple different platforms. And I'll leave it to them to share their data with you and the community, but suffice it to say that early work has been going on and we're seeing very good results. Lumira DX has also developed a direct antigen test using the SteriPack nasal swabs for their point of care instrument that has a very low cost consumable, and hopefully you'll be able to evaluate that technology in the future. The University of Washington, through our grantee, Jerry Cangelosi, has been has been evaluating the use of the tongue swab for SARS-CoV-2 and for TB detection, and those data should be available soon. So I think I can stop there and would be happy to take any questions that you might have been thinking about or would like to participate in a discussion. Thank you very much.
Thank you very much, Karen, for the very informative presentation, quite informative indeed. And I liked the bit where you talked about temperature and which really fits most of our environments here. It's time we need to get into a question and answer segment. So I'm going to quickly move and take some questions. Let me take this one from Hasfa Madani, and he or she says, what is the exact composition of the VTM compared to PBS?
So VTM, it depends on the different manufacturer that makes it. Typically VTM has some antimicrobials that are in the VTM. There are also buffers and I believe salts, but each different manufacturer has their own cocktail. And I wouldn't say that the antimicrobial properties are so robust that they don't prevent growth of microbes in that material, but when refrigerated, they're a little bit more stable. I believe there are sometimes chemicals in there that can inhibit certain types of enzymatic reactions like PCR or LAMP, and it really is an assay by assay, cocktail by cocktail equation, and so there's no set answer.
All right, thank you again, Karen. And this other one came from Abdul Mumin Sad. He says, it will be interesting to hear from the presenter any considerations for the environmental impact of 1 billion polyester swabs being manufactured.
Well, as far as discarding the swabs, I would say that one of the things that's nice about them is that they're very small, and the collection itself is, and the collection kit uses really a small amount of materials. And in fact, you don't have to undergo a vessel change in the laboratory. You can use that tube for elution and then go directly into extraction or go directly into PCR potentially, which might actually require less consumable materials that would have to be discarded. I think there's no getting around having to have some kind of material. We haven't evaluated whether these are good for incineration or other disposal methods, but they're certainly not very large. And I don't believe the manufacturing process itself is different than other manufacturing processes for swabs. So it doesn't seem that it's any worse than the ones that have already been developed.
Yeah, thank you very much. Yeah, and it ties so much, I think, with the question that came also from Pascal on how these are discarded and any special recommendations for waste management.
Yeah, I would consider them all to be, biohazard waste, just as you would with any of the other specimen types. And so, I'm not an expert in disposal of materials, so I wouldn't be able to speak with authority, but the materials that are used are similar to other, materials that are used for laboratory use. And so I don't know that it would have anything different, but I would consider anything that came in contact with the swab to be infectious. The VTM doesn't include an agent that renders the specimen non-infectious. So this isn't a different method than what the labs are used to. These should all be considered infectious.
Thank you once again. And this one came from David Oching, and David says, thanks again. This is really interesting. This is a really interesting study on dry tube usage. I know you touched a bit on how this could be applicable to other diseases, and this is what David is asking. Is this applicable or suitable for both naked and enveloped viruses? That is his question.
You know, we haven't looked at other viruses specifically, and so we would need to do more studies around that. I can tell you, though, that anecdotally, I have heard that there are clinicians in the US that have been using a dry format for viral collection and sending to the labs. And so this wasn't a new method to them, and that they were familiar with using a dry tube. And I've also spoken to others in the public health laboratory system in the UK, and they also concurred, these were clinical microbiologists, and that they have been using dry tubes for a while. And so this was really compatible with what's being used other places. But certainly you would want to, you know, validate the stability there. The thinking, though, that a dry tube would actually be more stable makes sense, because a lot of stability studies in food and other products have demonstrated that the water content is directly correlated with the stability of food and other products. And so without a very moist environment, you get a lot better stability. And I think that everybody is sadly beginning to learn that this particular virus is very, very stable. And, you know, for this application, I think it makes a lot of sense. It's consistent, but it's not clear whether that would have the same for other viruses. And so those studies would need to be done.
Thank you very much. Let me take another question. I know we're almost towards the end of this session. So moving from David's question, I think this one is coming back to PBS, and it's from Floret, who agrees with PBS saving the day. And he or she says they've just recently had an experience of PCR inhibition related to 2 types of transport media. And elution volume also depended on the template preparation method or even the PCR kit in use. Tac path assay was more robust when using the crude lysates compared to the Outplex assay. And these are some of the assays that we have presented here. So thank you very much, Floret, for sharing. I don't know whether you have some comments there, Karen.
Yeah, so, you know, it depends on the enzymes that are used, on the degree of inhibition by contaminants related to the specimen or to transport media. And there's been some really nice work done by some individuals at Andy Ellington at the University of Texas in Austin, who's been studying LAMP amplification. And he's developed some novel enzymes that are less sensitive to contaminants in specimens, and those may be used for LAMP in a direct amplification method as well. And so I think that it might be useful to explore the particular method and the enzymes that are used if you want to use a dry and direct elution into a reaction buffer. But certainly others have been trying this, and some early results are demonstrating that at least for SARS-CoV-2 and out of the nasal cavity, that there's not a lot of inhibition using different methods for amplification.
All right, thank you very much. Let me take this last one from Devi Emperado. And she says, are there any plans for similar equivalence or stability studies of dry swabs for antigen-based rapid tests?
So we don't have any planned per se, but we're working very closely with the IVD manufacturers that are making antigen-based tests, and we're trying to encourage them to use self-collected nasal swab. And you know, as far as stability goes, it's probably less of an issue for lateral flow tests where a specimen might be collected and then tested right away versus an instrument-based method. I don't believe, though, that antigen is going to be as stable as long as RNA. And our grantees at WITS, Wendy Stevens and Leslie Scott, have started some studies looking at antigen stability, and it doesn't look like it's going to be as stable for as long as the RNA. And so probably in the case of antigen testing, you would want to collect a specimen and test it within a shorter period, or place those specimens on ice. So it may be that molecular testing is more robust and the RNA is more robust, and antigen might require quicker testing, or using some kind of cold chain to preserve the specimen.
Thank you, Karen, for that. Interesting indeed. Talking about antigen testing, and this will be the subject of our next session, which is coming tomorrow. So please make a date and join us around about the same time. It's been a wonderful presentation. I know we are reached to the top of the hour. We will send the remaining questions to Karen to help us respond to them, so that we share with you as usual. It has been a wonderful session, full of information. Thanks to Karen and team. It is for me to just thank all of you who have come as usual in numbers to this session. We appreciate you coming through. On the screen right now is the codes for those that want to download the certificates to acknowledge your attendance of this session. Please visit the Academy and explore. Always welcome you to become an ASLM member and receive the benefits of being ASLM members. Till we meet again tomorrow, same time. Good evening, good afternoon, or good morning, whatever you are. Thank you.
Thank you very much.